The biggest complaint I get from this conference is that people leave here and they say, my head is spinning. I don't even know where to begin. And what I tell people is you can simplify this process by doing it in 3 steps. Okay, so where do you live?
Here.
Oh, perfect. Okay, so step 1, you get a sperm test in Chicago and a blood test in Chicago. For sperm tests, we're not looking for perfect sperm. Remember, because through this process, you can fix a lot of the sperm issues. Okay, I just want to make sure that you actually are making sperm. Okay, and the second part is the blood test, HIV, hepatitis, infectious diseases. It doesn't matter if you're HIV positive. It doesn't matter. We will still treat you. I have a lot of HIV positive patients, as a matter of fact. We just need to make sure that we process your sperm correctly. So once that test is done in Chicago, we take a look at it, we're like, all right, looks great. Then we have you, because we're not located in Chicago, we have you fly to San Diego. And we just need 3 hours. And what happens in the 3 hours? You give me sperm again, and that sperm will be frozen, and that's when we actually use for the treatment. You do blood tests, but that blood test goes to a special lab that's been approved by the FDA, and that's mandatory. And number 3, we give you a tour of our clinic, and that's it. And after the 3 hours, you come back to Chicago and you don't ever have to step foot in our clinic again. Okay, so that's easy. So that's step 1, getting the sperm ready.
And you can just get the sperm test from your primary care physician?
Yeah, absolutely, yeah. I mean, we'll give you the list, but yeah, easy.
And sort of weird question, but what do you do to prepare, like, is your sperm better if it's been a couple days? Like, how do you?
Yep, not a weird question. So the best quality sperm is sperm that's ejaculated every 2 to 5 days. So when you do a sperm test, if you know, all right, so I have my analysis on Friday, make sure you don't ejaculate on Thursday, because that's only a 1-day difference, but make sure that you ejaculated in either Wednesday, Tuesday, Monday, Sunday, or Saturday. Okay? The other thing is a lot of guys say, oh my gosh, I'm having a sperm test. Okay, I'm going to eat really healthy for a week, and then it doesn't work that way, because sperm takes about 90 days to be manufactured. So any change in your lifestyle now doesn't become evident really for 3 months. Okay? So that's part 1, getting your sperm done. Super easy. Okay, part 2 is creating the embryos, and that requires an egg source. And most people will use an egg donor. We have our own egg donors. They are all medically vetted. What that means is we have them fill out the application, we did the medical testing, we did the genetic testing, their psychological testing, ultrasound, blood test to make sure they have enough eggs. Okay? And only then do we put them on our website. Our website, which is eggdonors.com, okay? Free to use, you just have to create a password. And on that website, we have the photos of the donor, medical history, family history, educational history, have they donated in the past? And if they have, we write how many eggs did they get, how many were mature, how many fertilized, did they get pregnant, how many were frozen. Cycle number 2, same thing. If they were never donated, it says they're a first-time donor. We have their compensation. We have their when they're available. Some of them will say, you know, I'm busy with school, but I'll be free in July. And some say I'm available right now. And then we have something called antral follicle count. I've seen it on the slides called baseline follicle count, but they mean the same thing, and that tells you the potential number of eggs to expect in a cycle. Okay? In your case, you have 2 sperm sources. So when you go through these profiles, you don't want to pick an egg donor who has an antral follicle count of 16, which is great for a single sperm source, not great for 2 sperm sources, because I'm going to have to divide those eggs in half, and that's 8, 8. And if you remember from the slides, there's a loss of nutrition rate. So if you start off with 8 eggs, you're really going to end up with 1, maybe 2 embryos each. Not ideal. So you want to pick an egg donor who has an antral follicle count of greater than 20. So if she's got 26 eggs, 13 for each of you, you may very well end up with 3 to 5 embryos each. Okay? So once your egg donor takes a medication, we create the embryos. And then the whole topic of, do we do PGS, do we not do PGS? So if you are going to do PGS when your embryo is 5 days old, we biopsy and then we freeze. If you're not going to do PGS and when it's 5 days old, there's no biopsy and you just freeze. And that's easy. So part 1 was a sperm, part 2 creating embryos. You're 2/3 of the way there. Part 3 is actually the hardest part, which is a carrier. So we do not have a surrogacy agency that is absolutely intentional. It's just a lot of work. But we work with all the surrogacy agencies, including the ones in Chicago. So since you live here, my advice to you would be do it here because it's more affordable. Why is surrogacy more affordable here than in California? California is the most popular surrogacy state in the United States. It has the friendliest surrogacy laws, and for that reason, there's a huge demand. So at our center, we do over 1,000 cycles. About 60% of it is egg donor surrogate. And so just to give you an idea of just like the demand, but because there's a demand, the surrogates are able to also ask for higher compensation. So it's probably gonna be about 20% cheaper if you did it here. Okay?
So when you're transferring, like first transfer, is it, the answer is probably yes, it's best to use the best possible embryo. But like what if the surrogate ends up like, oh, they're actually not a very good, I guess my fear would be what if you use the best one and then it's like,
It doesn't work.
it was not right. It was very fertile and successful 5 years ago when she had her 2 kids, but now isn't. So how do you calculate those risks?
You're right. And there's really no way to predict that from happening. So you do the regular testing on the surrogate. And it's true. You know, if you do this long enough, this will happen to you where you have a surrogate and on paper she looks fantastic. And for whatever reason, she's just not getting pregnant, right? And every clinic has a different success rate. In 2017, our rates per transfer were between 80 to 90%. So you should be getting pregnant first transfer. But if not, I don't stress out. I'm like, I know it's disappointing, but hang in there. This is probably going to work the second transfer. So for us, if you're not pregnant the first, you're usually pregnant the second transfer. But what if you're not, right? Yeah, has it happened to me? Absolutely, it has. At that point, after 2 unsuccessful transfers, I have a discussion with you guys, and I say, all right, so here are things that we can do to try to improve implantation rates, many of them not based on great data. Or the question then is, why are we working so hard to get your surrogate pregnant, right? Maybe it's just not a good fit. For whatever reason, I don't know. And I'll tell you, most intended parents, after 2 unsuccessful transfers, because they really have a good relationship with the surrogate. But what I don't want to do is do the 3rd transfer exactly the same as the 1st and the 2nd, right? So let's say you 2 said single embryo transfer, right? And we give patients the option of 1 or 2. We're one of the few clinics left that still will give you options of 1 or 2. One of the things I'm going to say in my conversation is maybe it's time we transfer 2 embryos for this 3rd attempt. Okay, and you don't have to agree. Okay, or maybe we do treatment for endometritis or a biopsy for endometriosis or ERA. I mean, I'm going to list a slew of things that we can do for that 3rd attempt. If that 3rd attempt is not successful, then for sure I'm going to encourage you guys to find another surrogate. And I usually don't have an answer, but that should be the case, because if I saw a red flag, I should never have suggested her to be your surrogate from the beginning. But to answer your question is, gosh, do you put all your eggs in one basket and transfer the best of the best? Because if it doesn't work, what if you're left with mediocre embryos? And I will tell you, and this is based on clinic, but I think most clinics here at least are high quality, which is we don't freeze poor quality embryos. So if I don't think you're going to get pregnant, I'm not going to freeze it. So if I have an embryo frozen, that means I'm telling you, you have the potential of this to become a baby. So even though it didn't get the top quality grade, it's not that it got a poor quality grade, it just got an average grade, which can still be a viable baby, absolutely. Because again, you do this long enough, it will happen to you. I have transferred our top quality embryos and I'm like, yeah, this is gonna work. And I'm like, oh my gosh, how did this not work? And I have transferred, because that's all they had, like the embryos looked okay, that was all they had. And we started the conversation, okay, so let's strategize for the next cycle, and bam, they're pregnant. I'm like, right, that just shows how little we actually know. Because this is all like really subjective, visual assessments if you had not done PGS, right? So my advice to you would be, out the gate, you go with the best, because you really want success the first time, because the more you don't have success, the more disheartened you become. I would say you go with the best out the gate first transfer and cross your fingers that it will work.
So given that you clearly think doing two is medically okay because you do it.
As long as we have a conversation what that means and are you willing to accept the risks and the consequences, which we discuss in depth.
So what sort of, I mean, I sort of know the risks and consequences, but thinking about everything from cost to risk to surrogate health.
Yep. And that's the biggest drive. The reason I get is we really want to transfer to, because I'm going to be honest with you, I don't know if we can afford to do this again. It's like the most common reason I get. And I get it, because it'll cost you maybe an extra $20,000, but you get 2 babies for 1, right? But the risks of delivering 2, well, first of all, when I transfer 2, there's no guarantee that they both will stick. Our twin rate ranges between 40 to 50%. So if you flip that, if I have couples who come to me, they say, I really want twins, I really want twins, I really want twins, and I tell them, I will do my best, I cannot guarantee it. And of course, they're usually the ones who, when I transfer 2, get only 1, right?
Of course.
And there's the one who doesn't want the twins, when I transfer 2, they get 2, right? So I tell them, like, when I transfer 2, there's a 50 to 60% possibility only one's gonna stick. And they have to be willing to accept that.
Yeah.
But when your surrogate's pregnant with twins, the risk of diabetes goes up, high blood pressure, the risk of preterm labor, preterm delivery, right? And if she delivers, so most twins are ready to come out by 36 weeks, great. But if the baby is at 30 weeks, it's not so great. And that's where you get into trouble with the baby needing ICU care. So we call it the NICU, Neonatal Intensive Care Unit, which again, you live in America, so thankfully, usually you will have insurance coverage for the baby, but you can imagine if you don't live in this country, because we have a lot of European international patients, the hospital bill is exorbitant, right?
If a surrogate was a previous carrier of twins, is that an indication that she is more likely to be successful at carrying twins, or is that just sort of, there's nothing to support that?
Yes and no. So it tells me, wow, her body is capable of carrying twins, so I'm less concerned, yes. But if she's never carried twins, is that a red flag for me to say to you, I don't know if she's the right person to carry to it? No. Like if she's had singleton pregnancies and they've all gone well, and you two say to me, you know, we would really like to transfer 2, you understand the risks and you say, I get it, but it's what we want. I'm going to say, if everything looks great in her record, I'm going to say she's an appropriate candidate. Even though she's never had a history of it, I will say she's an appropriate candidate. But if the question is, if she's had twins before and I transfer 2, is there a greater likelihood that both of them will stick? The answer to that is no. Yep. Good questions. So then your surrogate gets medically vetted by us just to make sure she's appropriate. And one of the things that we are known for, I think it's a good thing, but many IPs get frustrated with us, is how many surrogates we reject. And there's a reason for that, right? The goal is, and I have to sometimes tell intended parents, the goal is not embryo transfer. The goal is a healthy baby, right? And if I see her medical records and I'm like, wait, it's not that she lies. Sometimes they don't understand and they don't remember what happened in the past pregnancy. So we get the records and I'm like, wow, like what happened? Like I had a surrogate who had a blood transfusion, has no memory of it. And I really believe that she's not lying. Like because the whole experience is just so emotional. She really has no memory of it. To me, it's a red flag, not because she can't remember. It's a red flag about her ability to deliver safely again. Okay, thanks. And so that's where it depends on the red flag. Like for me, I'll say to you guys, I'm not so sure. She's definitely not ideal for twins, but for singleton, let's talk about it. Let's talk this through, okay? Sometimes it's like a big thing for us. Body mass index, we are big on that. Our cutoff, we prefer 30 or less. We will go up to 32. 35 BMI, 34 BMI, no. And a lot of the agencies get frustrated with us, but again, like we have to remind the agency and the intended parent, the goal here is not just get a transfer done. The goal here is healthy baby. And obesity comes with increased risks when pregnant.
So if, and I don't have this situation yet, a surrogate that was someone I knew who wanted to do this surrogate.
Yep.
That, am I correct in understanding like the first time they would really be screened is through you? Or would they get screened through my agency first and then again by you?
Through us. Because you don't, if it's somebody you know, you don't need an agency.
Okay.
It'll save you a lot of money.
Yeah.
No, so what I do is I have a private conversation with them over the phone or Skype, whatever they want, but it's just me and her. 2 reasons. Number one, what if I unearth something in her medical history and I'm like, oh gosh, but you don't know, right? I'm not gonna call you and tell you, So can you believe Joanna has, right, I'm just going to say there are medical reasons why she's not a great surrogate, end of story. But the converse is also true. What if she's medically great and then I talk to her and I say, so this is the process, and she says, wow, really? And I go, yeah. And I said, are you comfortable with that? And she's like, you know, I actually didn't realize it was so involved. I don't know. So then I'll say to her, okay, right, because I want to preserve your friendship, right? So I'll call you and I'll say, okay, for medical reasons, your surrogate is not a great candidate. All right, and that way you'll never know what the real reason is. All you'll know is that there was a good medical reason why she couldn't carry. But if it's your friend carrying, I'm a lot more lenient. Not because I don't care, it's because she's your friend.